Session. David Shepard is going to be moderating the session on current concepts in trauma of the foot and ankle, an exciting topic that affects all of us globally. So David, it's all yours.
Thanks very much, Selene, and thanks very much for the opportunity to be involved in this global town hall. And I've seen some great friends and colleagues online from all around the world. It really is an honour for me to have a faculty from New Zealand, Dawson, Muir, Pete Stavrou from Adelaide, Jeff Ling from Sydney, and Tim Schneider in Melbourne, and myself in Melbourne. Just briefly, Dawson Muir's an orthopaedic surgeon based in the North Island in New Zealand. He's done fellowships in Iowa, the Royal Children's in Melbourne, and Chelsea Westminster in London. He's got an orthopaedic practice that does foot and ankle elective and trauma conditions. Pete Stavrou is based in Adelaide. Pete's an identity on the Australian foot and ankle scene and represents Adelaide strongly. He's had fellowships in Toronto and in Brisbane. He's a recipient of the AIFS Travelling Fellowship, and he's an active member of the National Joint Registry in toe ankle replacement in Australia. Tim Schneider is a very experienced member of the Australian Foot and Ankle Society community. He had fellowships in Galveston in Texas, and then in Italy with doing Ilizara frames. He's had a international fellow assigned to him for almost over a decade now, and does a lot of innovative trauma and reconstructive and elective foot and ankle conditions. And I'm based in Melbourne and did fellowships in Oxford, and have come back and actually in Tim's practice doing elective and foot and ankle conditions. And finally, Jeff Ling, trained in New South Wales. He had fellowships in North Shore, and then hospital accessory surgery in New York, and Shriners in Oregon. And Jeff's a director of training for the Orthopaedic Association, and is a secretary of the Foot and Ankle Society. So it really is an honour, and I'm almost filled up 15 minutes just talking about how great these guys are. So thanks very much. So I wanted to talk about just the general discussion on current concepts of trauma in foot and ankle, and wanted to focus on syndesmotic injuries, deltoid and Lisfranc injuries. And I'm just trying to advance. And in that, I wanted to really speak to the members of the faculty on the diagnosis of these injuries, and essentially who to operate on, and our post-op management. And there is some subtlety that in who to operate on syndesmotic injuries, deltoid injuries, and Lisfranc injuries. So in terms of syndesmosis injuries, I was wondering, Stav, if you presented on this to the Foot and Ankle Society years ago, and talked about some of the reasons why syndesmosis injuries can be troublesome in terms of pitfalls. And I wonder if I wanted you to talk about that just a little bit.
Thank you, David. Thank you, and welcome all. Yes, this is based on some research done over 10 years ago, and we looked at the reoperation rate in syndesmotic injuries, and found that this was actually higher than we suspected. It was over 20%, and we found 3 modes of failure where reoperation was required in these injuries, and these are listed on the screen there. The failure to diagnose the injury, so needing to go back and fix the syndesmotic injury after fixing an ankle fracture, failure to adequately reduce the syndesmotic injury, and finally failure of fixation. And surprisingly, considering what we find in the literature, failure of fixation is actually the least likely mode of failure. Failure of diagnosis was almost half of the injuries that needed reoperation were due to failing to diagnose the injury. Reoperation was about a third, and only about 1 in 5 were due to failure of fixation. When you look at the literature, which seems to be all based on this fixation is better than that, or this technique better than that, I think the key message here is you need to make the diagnosis. You need to get a good reduction. Once you do that, the rest will generally sort itself out. In terms of diagnosis, obviously the mechanism of injury, and these can be very high energy injuries, and here the diagnosis is relatively straightforward. But what we're talking about today and going to mostly talk about is the the low energy injury where there isn't a fracture, so it's purely a soft tissue injury where the diagnosis is not so obvious. It's not black and white. We're in the sort of grey zone here. So it's making that diagnosis with that history, and obviously the delayed diagnosis, the chronic presentation of an injury, not due to the fact that fixation has failed, due to the fact that there's not been a diagnosis for some period of time. Obviously, X-ray is crucial. You want to look for widening on an X-ray. In the soft tissue injury, that may not be obvious, so a weight-bearing X-ray is a good idea. It may take some days or longer for the patient to be able to do that. If you're in doubt, then a contralateral X-ray to see if the anatomy is the same on both sides. I have access to a weight-bearing CT. Some may not, but that's a great tool that's allowed. You can compare both sides, and there are algorithms and numbers that David will talk about later that will show you that. And obviously, there's arthroscopic tests if you're proceeding to surgery to assess the syndesmosis arthroscopically before fixing it.
Yeah, that's great, Stav. And what I thought, I'll just, based upon that, I wanted to put up two cases. This is a 25-year-old semi-professional Aussie rules footballer who just had a classic foot that was planted on the ground, and someone came in and tackled him, and that foot stayed, but his whole body rolled the other way. So essentially, the ankle had that planted eversion and rotation injury, and then he got sent in at 2 weeks and by a sports physician. So he already had an MRI scan, which shows this at least anterior ligament and probable interosseous ligament injury. And in Victoria, they get sent in with a weight-bearing CT scan if they've seen a sports physician. So that's an easy, relatively straightforward ligamentous injury diagnosis, probably. And then we have this other case of a 19-year-old professional snowboarder who was in a half-pipe competition and really didn't know what he did to his ankle, but had an ultrasound and was treated as a traditional ankle lateral ligament sprain. But he came back after 4 months or 3 months to Australia, and he could walk, but like a lot of those delayed chronic syndesmotic injuries, they can walk, but they can't squat and do stairs or run and do that higher function. And a very unremarkable examination. So where to from here? Imaging from here. So that's this chap here had an MRI scan and CT scans, but I just wanted to ask anyone that, like, who finds that in these, apart from an acute injury, even then, how reliable is like examination? Like, Stav, this is one of your slides, mate, in terms of just these traditional tests. Do people get much from this?
Oh, look, I think, any single test is often has to be, corroborated by the other symptoms and signs in history. I personally find the dorsiflexion external rotation test a better test than the calf squeeze test. So if I have someone who has a history suggestive of this, their tender, again, over the syndesmosis, a bit higher than the ankle joint itself, which you might find with an osteochondral lesion, and they have the dorsiflexion external rotation, I'm very suspicious of the injury, but I wouldn't say for sure they had it until I confirm that with some sort of imaging. Yeah.
Tim, I was just interested, do you reckon you get much from stressing the syndesmosis clinically?
I find it a slightly underwhelming examination, and I always do it. And I've tried a number of different techniques in a number of different people, but you always get a certain number of patients who it doesn't really yield very much, even though you've got a high index of suspicion because of the location of their injury or the mechanism of their injury or their scan results. And I think it's like every investigation, whether it's a physical test or a sign or a scan or something, that you have to take it all with a grain of salt. So if the person doesn't have terribly much to show on one of these investigations, that's not a game changer for me. I think you just sort of got to put it all into the pot. We don't have an absolute answer or an absolutely perfect algorithm for these things. So you end up with a subgroup of people who you think they're not getting better. They've got pain in the right spot. They want to go back and snowboard or ski or play football or whatever. So you do end up arthroscoping them or exploring them somehow. So I think that we've got an imperfect set of tests so far.
Yeah. Yeah, I think that's where it's, and I mean, we can probably agree that it's unlikely you're going to see, it's not common you see anything but a normal X-ray and the normal parameter, and often these normal parameters of the syndesmosis will be on a lot of these ligamentous injuries. Is that what you guys find?
Yeah.
And so I'm interested to ask that you guys, like in an MRI scan, like, so it's obviously a static investigation, but if you see someone come in with, if you get an MRI scan that's got 1, 2, or 3 ligaments injured, like 1 or 2, that could still be one, at least the anterior ligament, traditionally we'd say that could be a stable injury, the deltoid's intact. But if you see someone come in and you're suspicious and they've got all 3 ligaments ruptured, do you find that, would you move on to surgical fixation based upon that in a purely ligamentous injury?
Yep.
Jeff?
Yes.
Would you, I would too.
I would perform a diagnostic arthroscopy in that setting.
Would you? Yeah.
And in Sydney, we're a bit behind Melbourne and Adelaide, it seems. And we don't have a weight-bearing, I don't have access to a weight-bearing CT. So my dynamic test is arthroscopy. And
I'll bring your slide up in a second on that as well. Yeah.
So Jeff, when you do your arthroscopy, what exact parameters do you use to say this one's unstable enough to require something?
Yeah, so
I might cut to that now then, Jeff. I might cut straight to that while we're on it. This is your slide.
So there isn't, I would agree that there isn't great guidance in the literature as to what is normal coronal plane displacement between the fibula and tibia on arthroscopic assessment. There are a few cadaver studies. So this is on the slide here, you can see this is a review, a systematic review, and they dug up 4 cadaveric studies that showed when they sectioned all the ligaments, they could displace the distal tibia fibula joint about 3 millimeters anteriorly and about 3.4 millimeters posteriorly. So I use, as a result of that, I use a 3.5 mil shaver and my probe as well. And if I can, in the setting of a positive MRI scan, positive historical and physical exam signs, and the ability to push my shaver into the joint, to me, that's an unstable synesmosis that needs fixation.
So this is what you're talking about, Jeff. That's a 3.5 millimeter shaver.
Yeah.
So that's positive. Yeah. I mean, this is one of mine. It's not one of yours, so it's hard for you to comment.
Sure. Yeah. I mean, that looks positive. Interestingly, there is a subset of people with generalized ligamentous laxity, in my experience, in whom you can actually displace the distal tib fib joint at least 3.5, 4 millimeters, and they don't necessarily have a synesmosis injury. So it does, obviously, it's not a...
Sorry, Jeff.
So it's certainly not the be-all and end-all, but I would say that for the vast majority of the population, being able to displace that distal tib fib joint with that size shaver is abnormal.
Yeah, I think that's what you're alluding to, isn't it, Tim? And I think, like you said, it's an amalgamation of, it's adding up the points to get a sort of gross overall score, because, certainly we've all done those scopes where in someone who doesn't have synesmotic instability, you're scoping them, and inadvertently you just wobble their fibula around, and you think, well, crikey, that thing's moving. That's really moving. And so you think, well, how does that affect the case I did earlier on where I diagnosed them with instability? Do you know what I mean?
Yeah, what you're seeing is a lot of rotation, aren't you?
Yeah. This is just the picture of the posterior ligament where you often see it torn away. I don't know about you. This is the bottom screen that's showing now. I find that if they have a syndesmotic injury, often you see this indentation in the medial mortise. Do you guys see that pattern? It's a really common sign in my practice. Do you see what I'm saying there?
Is that at the front, David, you're talking about?
So this is the bottom video is looking at the medial mortise, and I don't know why it's gone on now, but it's essentially got a small indentation in the medial mortise, and I find that to be a sign as well.
Are you saying that you see an indentation there, Sheps, because if the fibula's moved off the tibia and you're seeing a normal bit of anatomy that you shouldn't be seeing?
No, I think it's part of the injury commonly for some reason, and I don't know how it fits into the classic mechanism. But often, like this is the same.
You think it's an impaction injury of some sort in the cartilage?
It's an impaction injury. The bottom picture you see, that's the medial mortise there, guys. So I'm looking from lateral to medial, and often you see that little impaction injury when you've got in the context of all the other syndesmotic ligaments being injured.
Okay.
I find it a really common feature as part of your.
I must admit, I've never appreciated that, but I'm sure it's one of those things where I've not seen it, but it's seen me, sort of thing, I would imagine.
Now we'll all start looking for it.
Exactly right. It'll be everywhere now, David.
Mm-hmm. Yeah. So we jumped onto arthroscopy then, but one thing I know Tom Clanton, they did a syndesmotic session before, and Thomas Clanton has this fantastic cadaveric dissection series of papers where he sectioned the syndesmotic ligaments from front to back and then applied force. And it's really evident that the anterior ligament, no surprise, is the key restraint to external rotation and then subsequent posterior translation. And I think that is where that whole concept of the grade 1 or 2 traditionally syndesmotic ligament injury, we're trying to work out if it's unstable or not. And that gives some contribution to Tim. I don't know if you wanted to comment on what Jeff just referred to. In Melbourne, we're using a lot of this, and in Adelaide, this weight-bearing CT, which was published by out of Victoria, out of Melbourne, by a group of local surgeons, where we look at this non-weight-bearing and weight-bearing CT scans. And how do you use that?
We're fortunate in Melbourne because we have a very enthusiastic radiology service who weight-bearing CT scanner and quite a lot of time collecting data on people with syndesmosis injuries and correlating it with arthroscopic and clinical and surgical findings. And I think this paper was published last year. Havinder Bedi was probably the lead surgeon, and Andrew Rotstein is the radiologist who's contributed most to it. But there have been a number of others as well. And I think there are about 39 or 40 patients who've had preoperative weight-bearing CT scans and of both their injured and uninjured sides. Scan. So we're measuring the area between the tibia and the fibula at a set distance, and they spent about 2 years working out an algorithm to make sure they were always measuring the same area. So you ended up comparing like with like. There's a lot of work went into that, and eventually, after doing these 39 or 40 patients and correlating with the MRI findings, they found that it was a pretty sensitive test for picking unstable syndesmosis injuries. And I think the difference between the injured and the uninjured side of a weight-bearing is an area of about 10 or 12 or 15 millimeters, I think, from memory.
Yeah.
And when you compared the injured versus the non-injured on weight-bearing, so that was the unstable versus the injured versus the non-weight-bearing versus the weight-bearing was about 11 millimeters or 15 millimeters difference. And then when they compared the injured versus the non-injured, there was also a similar difference. So they were both quite predictive tests. Fortunately, this place is just around the corner from us, so we do get to use it quite a bit. And I think it's quite helpful.
Yeah. And Jeff, you'd be happy to know that what this correlated also to was there was a sidearm to the study where it was associated with positive swipe through tests, and what a positive swipe through test would associate with an unstable change in area, and that was roughly about an 8% increase. And so that sort of goes on to define a little bit what we think is unstable. So,
David, I think that's an important point because, as you say, I've had access to a weight-bearing scanner for a long time, but until this study and these findings, I would get a report that would tell me there's a difference from side to side with weight-bearing or between weight-bearing and non-weight-bearing, but I didn't actually know what the numbers meant. And I think this is a very important study you've alluded to. And I think that 8% figure you're talking about is the one that seems to be where the difference is between something that's a little bit different and probably stable and something that's unstable and probably needs some sort of active management on our part. I think that's very important to get that message out, because otherwise you're getting a bunch of numbers that without context and without what is significant and what's not.
That's a good point.
But you've also got to have the radiology department who are going to run the right algorithm.
Yeah.
Because the actual, you've got to do it the right way. Otherwise, it's meaningless, because they spent years doing meaningless studies and working out what they actually needed to, what they actually did need to measure.
Agreed.
Just one thing. Go on.
Yeah, no, you go, Tim. Oh.
No, I think you go first, David. I was just going to say that. As far as arthroscopies are concerned, I've sort of gone off arthroscopies because I ended up with too many people where I was unsure what it meant. So I figured eventually you're probably just better off opening it up and having a look at it, because if it's a pretty important injury, so I don't mind putting a longer scar on someone's leg for what's otherwise an important injury. We do it for all sorts of other things. So my assessment is to open it up, and I put a Bristow or an osteotome between the tibia and fibula and just see how much I can shift it.
So I reckon we've kind of covered this concept of what's unstable and trying to work it out, and so which needs treatment. And I think that's the idea, isn't it? So if we work out that something's unstable, how do you reduce it and how do you fix it? And as you pointed out, Stav, the most important thing is to recognise the injury, the diagnosis, and then fix it without malreduction.
Can I ask one more question?
Yeah, mate.
Does anyone use intraoperative fluoroscopy? Does that give you as much information as you need?
It's good. I don't use it. Does any? Yeah.
No, that's okay.
I think if I've committed to fluoroscopy, then they're probably on the way to surgery anyway. Yeah. I don't do routinely stress views or under anaesthesia or anything like that. So I think if I'm getting to that point where I've got intraoperative fluoroscopy, I think they've got a very high chance they're going to have something a bit more than just that.
Yeah, I agree.
I think after my fixation, I think it's value. But for me, in my personal practice, I wouldn't. That wouldn't be my deal breaker in terms of fixing them or not.
Yeah.
I think the other thing is that what I was alluding to with Tom Clanton's paper is that I think fluoroscopy picks up a diastasis, like a widening.
It's not going to adequately pick up a rotation, is what you're saying.
A rotation and a posterior sagittal translation, and that's my feeling about it. Whereas that's how the other, more sensitive tests can pick that up. So if we were to go,
that is also. Oh, sorry, David, interrupt. That is also the problem with the malreduction, is that you can translate the fibula often posteriorly and anteriorly and fix it, and on fluoroscopy it'll look perfect. That fibula overlap and that clear space looks great, but you've actually malreduced it because you've translated it. So that is the problem, So something in 3D, like this weight-bearing CT, is going to give you a fuller picture of where you're at, because you can look good on X-ray, but not have appreciated that translation.
Yeah, well, that's perfect to move on to this, Stav. So now I just want to ask: so if this was out of the faculty here, who would this first chap who's 25, he's injured all like a big injury, he comes in at 2 weeks. what would be the current? We've decided we're going to fix this, and what would, just moving around, how would you fix a semi-professional footballer who decided got an unstable injury? Dawson, what would you? How would you go on and fix this chap preferentially?
Well, for fixation, he gets an arthroscopy, and then I'd plan on arthroscopy in a closed reduction, and then obviously the debate is what you fix it with, and I've been happy with 2 screws. It's just whether you use that plus or minus a tight rope, and then you can remove the screws. But there's some reasonable evidence that you can leave the screws, and that's come from a paper in BJJ published by a couple of Kiwis. The lead author was a guy, Matt Boyle, and they ran not big, but they randomized over 50 patients, and no difference in their proms at a year, whether they'd remove the screws or not. So it just I don't know. It speaks to whether there's a significant advantage to a tight rope philosophically.
Yeah. So, and Jeff, what would you be doing?
So, as mentioned already, I rely very heavily on arthroscopy, and I think I've got a fairly good idea as to what constitutes an unstable syndesmosis arthroscopically, because I assess every distal tib fib joint with that 3.5 mil shaver, whether they have a syndesmosis injury or not. And if I confirm that this is unstable, then my preference is to use a tight rope or 2, and then I will reassess arthroscopically with my drive-through test. And interestingly, it's not uncommon after a couple of tight ropes that you can still push your 3.5 mil shaver through the distal tib fib joint. And in that setting, I'll supplement my tight ropes with a direct repair of the AITFL with an internal brace, which is a technique you're a big fan of as well, Sheps.
Yeah, that's right. Yeah. So I think
and it's quite amazing. After putting the internal brace in, it is rock solid. You just cannot get your shaver into that gap anymore.
Yeah, it's an interesting point. Sometimes I wonder if it's too tight. My removal rate's higher than just tight ropes for that. So I do wonder whether it's too tight sometimes. And I just thought that's a good, it's interesting, isn't it? You 2 different ways of fixing it. This is Tom Clanton's next paper where he then fixed it with either those same models, fixed with either screws or 2 tight ropes or 1 tight rope. And what was interesting in that external rotation, it was interesting that this shows that 2 suture buttons is almost as stiff as a screw, but 1 suture button gives you that mobility that you're talking about, that things can still rotate and move and translate posteriorly and rotate. So I think we're all aware of some of the reviews that talk about outcomes, and you mentioned that, Dawson, that there's there's studies that show there's not much difference between the 2, but my take on it is that overall reviews would show that suture button devices are trending towards showing better outcomes, and certainly studies showing that there's usually a higher rate of malreduction and loss of reduction in screw groups. And so certainly I've been doing this I reduce it arthroscopically and do a tight rope. I clamp it arthroscopically, put a tight rope in, and then do an internal brace over the top with I think this technique's pretty well known by this stage, and I think Tim, you do that as well.
One of the things I wonder about is exactly how tight you make the anterior tibia fibula ligament.
Yeah, I agree.
When you're putting in it, and I do that technique, but I do wonder if we make it a little bit too tight.
Yeah, I agree.
The other thing is I don't do this arthroscopically. I do it under direct vision.
So I do my reduction under arthroscopically, but then I extend the lateral portal, and then you see it all open, and then you're on top of it to see it anyway. But I do agree that I've had to go in and remove these, and at 3-4 months, and you just extend that excision again, and then you end up finding the little internal brace and incising it with enough, and it seems to get better after that.
So I was going to ask you, David, is that what you do? Are you just dividing the fibre tape, or are you actually taking out the suture anchors and everything?
Well, that's a really good. No, I don't. I look for the fibre tape and try to make sure I don't cut the supposedly healed internal ligament underneath it, and then you find the little fibre tape and slide a artery underneath it, and then incise that. They've done okay. Often I've done an MRI scan prior to just make sure there looks like some good scar tissue there. And certainly this, I was just going to reference that this is a retrospective case series that I was going to present at IFAS, which just shows a follow up at 1 year of these of 46 cases with FWM scores. And at 3 months they had good return to sport, but I did have a slightly higher rate of removal devices compared to the literature, which is about 7% for tightrope only, and I was up to 11% really with this internal brace technique. So you can obviously make it too tight.
Do you think you've changed anything?
Oh, sorry. Go on,
do you think you've changed how you put them in since you've recognised this?
Yeah, I take it out to length and mark that, and make sure there really is that slack before you then impact it in, and I hold the foot in dorsiflexion for what it's worth.
Put a little mosquito underneath it or something like that as well.
Yeah, and I do that at the same time. So there is a fudge factor in that. I totally agree.
David, I think the one thing that you've got in common with Tim is when you're talking about this is that really the key is when you reduce this, you should be reducing it under direct vision. And whether that's arthroscopic or making a little arthrotomy and looking at it at the front, that's the key. If you're just relying on looking at it and reducing it radiologically, that's where you can come unstuck. So I think, it's got to be some sort of direct vision. Jeff's doing it arthroscopically, you're doing it arthroscopically, Tim's doing it open. I after my studies from years ago, I do it open as well, because I'm just not sure that radiologically I can be that happy that I've done it properly. What do you do, Dawson?
I'm the same. I mean, I'll do it arthroscopically if I'm happy, but there's certainly many incidences where I'll do it open.
I just want to
I think that's the key, is the direct vision.
I think that's a great way to finish off, Stav. And I'll just say one thing that I wanted to mention was that I have found this internal brace construct very helpful in chronic repairs. And this side, there's a lot of writing down there, but down the bottom, chronic injuries had really similar functional results, people beyond 3 months. But those people I definitely would open and openly debride the syndesmosis, as opposed to the fresh injury where you could put the shaver up and clear the muck and clamp it down. So I was hoping that, I think it's been a great discussion, and I was hoping that with syndesmosis, we just talked about that concept that I think that traditional concepts of grading are less relevant than just a thorough attempt at determining whether something's unstable and then appropriately fixing it and making sure whatever your technique is to make sure it's reduced, and you've got a fixation technique that maintains that reduction.
I think we have better tools at assessing the syndesmosis now than when those classifications were identified, and that's the key. Use the tools we've got.
I wanted to move on to deltoid injuries, because this is another field where I think that literature is probably even more sparse than syndesmosis in terms of associated deltoid injuries and what happens if they're not fixed, and when do you decide to fix it, and do you do it under fluoroscopic screening, or you base it upon MRI, and how does one fix a deltoid injury, or what variation, and even then what happens if they present in the rooms like that 30-year-old chap who walks in from a missed deltoid and they've got a flat foot, and you think, wow, what do I do now? So, Dawson, did you want to talk? This is a case of yours. Did you want to briefly run through this case?
Yeah, I could do it. This is got a pretty vexing case, really. He's 22, and he's had basically an anterior dislocation with eversion injury. So he's ripped the lateral ligament as well as the medial ligament, but the dominant injury is medial. And this is him a week post-injury. And then I think the next slide is just a coronal plane MR. You can see that his deltoid's exploded, his syndesmosis is intact, and that's an intraoperative fluoroscopy view showing the extent of his eversion. You could also dislocate him right out the front. So, I know what I did, but I'd be interested to know what the panel would do in this situation. So this was a guy who's got underlying mild cavus, who's ripped lateral and medial ligaments in his ankle. And the question, I suppose, is really reefing it in repair. Can you leave him alone? Should he have an internal brace to supplement his medial repair? What would others do?
Well, Dawson, this was back in 2014, I see.
Yeah.
So I don't think that internal braces and those soft tissue repair devices were as common.
They were around,
and as well understood.
Laterally, but not much medially. Yeah.
Yeah. Well, even still, I mean, we weren't nearly as comfortable with them then as we are now, and you have to repair this guy. I think that, historically we've left medial ligaments alone and just let them heal up. And in a lot of people they do, because it's probably got a pretty good blood supply and it's reasonably forgiving. But I think this is well beyond that. So I think you certainly need to repair that somehow. So to that, I would use an internal brace of some sort, some sort of anchor. But back then, I'd probably just directly repair it.
Yeah, well, that's basically what I did back then. And I did consider using an internal brace, but it was for all those reasons about being unfamiliar and having not used it on the medial side before. And a little bit of a fear that I might tip him over and his lateral ligaments were gone. And then I wondered whether I should do his ATFL as well.
Can I just ask you something briefly on that, Dawson? In not in a case just as bad as this, but in a case that comes in the room and they've had an ankle ligament sprain, and they've got a bit of tenderness on the medial side, and it's got that bit of medial bruising around the deltoid ligament. Yeah, but their predominant features.
They have a dominant inversion, and they
complain a bit of a medial pain.
I've never done the medial side.
But you can go in and scope them and do their lateral ligament. And now maybe I'm wrong, but I've been guilty of doing that and hoping that the medial side gets better. And most of the time I get lucky with it without touching the medial side. But if you miss it, it was the wrong thing to do. Don't you reckon? Or does everyone have that experience? Or am I not doing the right thing?
I think these days we spent more time gazing at these things, but historically we were taught by our fathers and our fathers' fathers that you could just leave them, and most of the time they were okay. But I think we're recognising now these people, and probably now that we've got a tool that we're more comfortable with, we probably would, our threshold for doing it would be lower than it would have a couple of years ago.
What did you do with this guy? This professional athlete, what did you do?
I repaired him. I mean, there's an anchor to repair the deep deltoid had torn off his talus, and the superficial deltoid was mid-substance, so I basically just reefed it. And then I suppose my next question is, where to from here? How do you manage this guy post-operatively?
With that, I would have put him in a boot with an arch support. And got him walking in that for 6 weeks, but let him come out and do sagittal range of motion during that 6-week period. But I would have kept him in a brace, just with a suture repair probably for about 10 weeks, but got him starting to do calf raises and some strengthening.
So you wouldn't keep him off it?
No, I'd walk him. I'd walk him, but support it.
Yeah.
David, when did you let him walk?
I would have treated him much more conservatively. I think if it was a direct repair that you did, Dawson, I probably would have casted him, probably non-weight. I wouldn't have let him wait there for at least 4 weeks.
Off it for about 10 weeks, but he had one of those anti-gravity running machines that he got back into a little bit earlier, but it was 10, 12 weeks before I got him walking.
You guys
Well,
talk a lot
work.
about the internal brace in this setting, but are you not concerned about over tightening in this setting?
Yeah,
And,
well, that was
and,
what I
and
was
why-
saying.
So we've got some cases coming up. We can talk about that. Yeah.
Okay. And why not
But
a
even-
biological solution like tendon graft or something like that?
Well, I used to use them a fair bit about 4 years ago, but they tend to stretch out, in my experience.
I've been a bit underwhelmed by them too.
Okay.
I've done
This-
them,
in
but
this setting.
I've done.
So that's a perfect segue, Jeff. We can move. We can. Well, was that a deltoid? What happened with the? Oh no, but not for the. So you're talking about a graft for deltoid?
A graft for deltoid, autograft hamstring or allograft, something like that. That's what I've used in the past. I've used a bit of internal brace as well, but really, it's in my practice, it's been such an uncommon problem.
I agree.
You end up with a case series. I've got a case series of 2 or 3 in each camp. So
I think that's a difficult thing, isn't it? The number you need to treat to prevent that late valgus that presents where you then have to do way more than just a ligament repair. So picking the ones that you need to treat. So Dawson, are these just the post-op? These are the post-operative images.
Those are, I think those are sort of 6 months down the line when he was still battling a bit, and at that point I did wonder whether I had to go back and do an internal brace and re-repair his deltoid. I was worried about him, but he did manage to get back, and he got back to the highest level.
Yes, and then he broke it again. But I don't think he broke that because of your deltoid repair, right? That was the proper injury.
No, he just tore the only remaining ligament that he hadn't torn in the past.
So you went on and fixed your syndesmosis, but I think in the interest of time, I'm going to move on to talk about, this is exactly what you're talking. This is a fracture where I fixed a Weber C ankle fracture with, in a 57-year-old male, and he had a valgus stress as well. And in a heavy 57-year-old diabetic, I wasn't prepared to just leave that one. Often you might, but I didn't want to see that plate, that mechanism where you see the plate snap and everything stretches out. And so I did a internal brace into his deltoid. But I do agree that when you're tensioning that, it's quite difficult to make sure you're not holding it in too much varus when you're doing that. Tim, you've got a couple of cases here of just purely ligamentous deltoid injuries as well. Did you want to discuss these?
I think Oh, sorry, Tim. I'm just going to say the real issue is when you're putting the limb of the internal brace into the sustentaculum, because then you can over-varize them. So if you were just going to put it into the tape, it's not such a big deal. But if you
so when I do it, this is just deep deltoid, and I pop it just into the top of the fovea there of the side of the talus. That's not, it doesn't go underneath the subtalar joint, correct?
Yeah.
Well, the other issue,
quickly,
David. Oh, sorry, Tim, to interrupt. The other issue,
No,
David,
you go, Steph.
Whether you need to look at whether this is an isolated deltoid injury or a deltoid injury in combination with other injuries. So if you've, Dawson's case had a deltoid injury with a lateral ligament injury, so if you've got an isolated deltoid with a syndesmosis or maybe a deltoid with a spring ligament, that changes the algorithm as to where the threshold for being more aggressive in terms of your treatment. So you need to think about that as well. And that will, what in one case you may think I'll leave. When you've got another injury, you may decide to do a bit more. And in your case, you had that diabetic one, you had a fibula fracture, you've plated it, so you've hopefully reduced the syndesmosis, you've put a tightrope in. But, I think that combination of injuries rather than just an isolated one may change your threshold for fixing the deltoid as well.
That's a good point.
Hey, David,
Tim, do you want to?
I've got a couple of questions that have come in.
Oh, yeah.
One is saying for when you're using the internal brace for the syndesmosis, how do you make sure you don't over tighten the internal brace?
Good question. I think I'd say that the I just lay that. I don't think there's an exact technique that can really test that. And I alluded to that in terms of the fact that I think my removal rate's higher than a tight rate removal. But I simply just lay the fiber tape over the top of the cinder, and advance that up to the side of the bottom of the swivel lock anchor, and then put the artery underneath it, but hold the foot in dorsiflexion. Having said that, I know that I think it's Rick Ferkel Jr. has done some studies on the position of the foot in syndesmosis reduction, and the concept of dorsiflexion or not dorsiflexion doesn't necessarily change. And that may be a bit, so that's not that accurate. So I'd have to say it is not in my hands, I don't think it's very sensitive.
Okay. The next question is for delayed presentation of syndesmotic injuries. Do you guys use screws or tightrope?
Personally, I use tightrope and an internal brace.
Yeah. Okay. For delayed presentations?
Yep.
Definitely, yeah. I think that's partly, I think that answers that concept of the the horse is bolted on the biology there, and you can try and stimulate with your surgical insult some, new formation of a cytokine response. But you are probably going to rely a little bit on fixation that's going to hang around for a while, whether it's a biologic to the tissues or not. And I think
anyone else use hamstring?
I used to. I know you've got that in your presentation. Tim's got a paper on hamstring. Do you want to mention
how
that,
long
Tim?
will you guys wait? Like, what's the longest you would wait to reconstruct the syndesmosis? 3 months, 6 months? When would you say, you know what, game over?
I think you want to do this as soon as possible, but I've had people who've been out at 12 months. They've turned up at 9 months, and you're thinking, I don't know if you're the person who wants to go through all this surgery, and you kind of get to know them, and you realise after a little while that this isn't going to work. And they've been out to 12 months and actually done quite well. I'm not quite sure.
The longest one in my series, Selene, was 14 months post, and he had a very good FAAM score after fixation. But I think it's a combination. Then if you do an MRI and their cartilage is good, and they're at an age where they want to get back to their functional demand, what they want to do recreationally or with work, would move you down the line of fixation. I think it's worth reconstructing and debriding the tissue and trying those techniques. But my longest is 14 months.
Okay. All right, cool. Thanks, guys.
Yeah, we've only got a few more minutes. Tim, did you want to talk about this deltoid ligament case of yours? This is a case you operated on.
This sort of speaks to the deltoid ligaments are a messy business, because I don't think we really, in our minds, separate out all of the different kinds. Well, we probably do, but not as clearly as we should. And this is probably a more common presentation with a person who's twisted their ankle or done some kind of injury, and it's really just the front of their deltoid ligament. And again, we've just been taught to pretty much ignore them, and they're meant to settle down on their own, but they don't always. And this is a lady who was in a low-speed car rollover. She's a farmer, and because of COVID, and she couldn't get in and see me. So she was actually this was an MRI at 3 months, and there's some sort of injury to the deltoid there. You can see on both views, but her pain was very well localized on the front of her medial malleolus, and she was a very, very stoic person. And she said, "I just cannot do my job because my ankle is so sore." Didn't feel unstable. Her arch wasn't collapsing. Eventually, after we dealt with the insurance companies and COVID and whatnot, I did an arthroscopy, and the next case will show a similar finding, where you get this appearance of the deltoid ligament, which is stripped off the front of the medial malleolus. That's the next case there, which is the same. So I've got a bald front of medial malleolus, and I think there's probably quite a bit of this around. And if you go back to that last lady, I ended up, go forward, maybe, David. This is another case. It's almost exactly. I just put an internal brace in. over the front of the medial mortise and down onto the neck of the talus. And this guy's only 6 weeks out, but he's pretty comfortable. The other lady is about 4 months out, and she's returned to farming and says her ankle is fine now, and she wants to move on and forget about it. So I think that this is a subgroup that we see, and we've never really had a good way of dealing with it. And this is probably quite helpful. I'm sure eventually I'll put one in too tight, and we haven't really decided on what the anatomical suite is for this thing, depending on which part of the limb we deal with. But I think it's one of the subcategories we deal with.
Stav or Jeff, did you have any have you got anything to share or on the variation of deltoid, anterior deltoid instability, and fixation of it in just purely ligamentous presentations like that? Have you had things like that?
No, look, I don't have a lot of experience with this particular injury, but I think, again, it's about working out the diagnosis. And I've done deltoid injuries that have been more significant, and so I use a couple of anchors, one in the talar neck and one in the sustentaculum. But again, this particular injury doesn't span that deltoid that goes over the sustentaculum. So I think it's a very sensible way to deal with it. You're dealing with a limited localized injury, and I think obviously Tim's got good outcome with it. So I think that's a very sensible way to go about things.
I think in the past, we've just let them go, and I guess most of them get better, but this is the odd one that doesn't. And I've just had these two people turn up and pretty close to each other where they just haven't got better.
Can I ask, I've made the mistake of seeing a presentation on someone who's had a deltoid injury and it would be chronic and they've got a bit of valgus when you examine them. And I've gone in and just tried to do a deltoid type repair and failed, and really should have done a heel shift and done a lot more when the primary injury has been an acute deltoid tear in a young person who's come in at about 6 or 9 months. And my experience is that a repair at that stage isn't going to work. Is that?
That'd be everyone's experience, I would think.
Yeah. And would you, Dawson, would you do a heel shift then and add anything more?
Like gastroc as well, and you might need to address the supination as well.
Yeah, exactly. So you're moving into flat foot reconstruction, aren't you?
Yeah.
Yeah. Is that your experience as well, Jeff?
Yeah, absolutely. Yeah.
It moves into that whole acquired flat foot, isn't it? And the horse is bolted. Yeah.
Yeah, it's a spectrum.
Well, hey, Tim, there's a question for you from the crowd asking, again, about tensioning on the deltoid. How do you tension your deltoid repair using an internal brace?
If you make it too tight, they can't plantar flex. So you need to have the foot in a little bit of plantar flexion when you put it in, because that will definitely limit it. And I think that the message from the internal brace people generally is one of the mistakes we make all over the place is making it too tight. I always put a clip or an artery forceps or something underneath it, so there's a little laying over the ligament, because I think they run into problems when it's passively not doing much. This thing's not tight over the top of it. It's probably just at the end of functional range. That's where it needs to start taking up. So that's a bit of a vague answer. I don't really have. I don't think anyone absolutely knows that. And that's part of the problem with these things.
And actually, it's a good question, Selene, because I think that moves on to this. It may not just be over tight. It may be non-kinematic. And I've got a patient who, Chowniri's got that fantastic paper where he goes on and has done internal bracing from the sustentaculum up to the deltoid, and with internal brace. And I had to remove remove an internal brace recently in a lady who just felt fantastic. All her medial pain and the flat foot's gone, but she had this new pain over the anterior deltoid region, which I'd never really seen before. It was this. She clearly described this atypical post-surgical pain. And I watched it for a bit and went in and just made a small incision and dug down and found the internal brace and snipped it, and it took the pain away. and it wasn't over tight. It was just the non-kinematic, because the deltoid's quite a complex structure, really, isn't it?
Yeah, and I've seen that a few times too, where I've then just taken out the internal brace and the pain gets better.
Yeah, yeah.
The good thing about this is you don't have to do a big operation. You just make a little hole, cut the internal brace. It's now redundant. It's just sitting there, and the person's walking on it the next day. So it's quite a good bailout, really, for in that situation, I think.
So I think it's a lesser evil to have for not treating the injury. I think it's certainly a much lesser evil just to do that for over tightening than having someone's foot arch collapse.
Well, we've got 2 minutes, and we clearly don't have time to go into Lisfranc injuries. So we had some great cases here, but it's been a really great discussion, and I've just really enjoyed the chat with my colleagues in New Zealand and Sydney and Adelaide and Melbourne. Thanks very much for being part of it.
I want to ask you guys, obviously we've mentioned internal brace a multitude of times, but there are other products that are similar. Do you guys have any experience using Ardilon? Is that available in Australia?
No, I wish we'd been saying a polyethylene braided construct rather than that. Trap, isn't it? I apologise for that.
No, I want to know what you guys think.
No, I don't have experience with it. Is it a polyethylene braided construct as well, or?
It's a synthetic graft that over 5 years becomes the patient's tissue, and and it's they've been using it initially for ACL, but now it's launched in the foot and ankle here in the U.S. So I didn't know if it was available globally or not, or you guys had access to it in Australia.
Not that I'm aware of.
Gotcha.
But it's interesting to hear.
Yeah.
The other issue that Jeff alluded to earlier was about using an allograft tendon. That's also something we don't have a lot of access to here. Where I work, the tendon, all that sort of tissue has to be irradiated, and that kills the collagen, and you may as well put in a shoelace. It'd probably be better. So I think, I don't know, certainly in North America, allograft